very pleased to be here today to speak on one of my favourite topics, managing chronic pain in patients with substance use disorder, and particularly today with opiate use disorder. So a couple of things just before we get started. We have financial support from Health Canada and GPSC, but the views here do not necessarily represent the views of those organisations. Disclosures for myself: I have received honorarium, speaker fees, and as an advisory board member for Indivior, and an honorarium for presenting today's session. The BC Echo on Substance Use has received also financial support from Health Canada and support in kind from the BCCSU. In order to mitigate any potential bias, the content was developed and reviewed and validated by members of an independent scientific planning committee, approved for accreditation, and we will endeavour to use generic pharmaceutical names wherever possible. So let's get started. What are our learning objectives for today? So we should be able to describe how substance use and injury can alter pain sensitivity, and outline approaches to acute and chronic pain management for people with opiate use disorder using opioid agonist treatments such as buprenorphine, methadone, and slow-release oral morphine. Chronic pain is very prevalent amongst the general population in general, but certainly higher in people that are on opiate agonist therapy for OUD. Anywhere in a range from 35 to 70% of patients do report significant chronic pain issues. Chronic pain is always associated with higher rates of psychiatric symptoms such as depression, anxiety, somatizations, and also with use of non-medical substances such as benzodiazepines and cannabinoids. What happens when an individual has chronic pain? It's not just the pain they experience, we actually undergo specific neurological brain changes. So we know that pain is extremely important as an adaptation for responding to acute injury, but it's not so good when that becomes chronic. Here, brain connectivity becomes reorganized both functionally and anatomically. So that means we can see it on MRIs and to a lesser extent CTs, but specifically functional MRIs. And we can measure all sorts of changes in terms of function of the brain in other ways. So the nervous system can act to either magnify that pain sensation, can dampen it, or filter in other ways the transmission of pain signals. The specific areas of the brain where this is involved include the nucleus accumbens and the prefrontal cortex. And they're constantly activated and eventually become kind of under-functioning. This can often result in low dopamine states, which again increases pain sensitivity. And then stress neurohormones are released when a person is in pain. And these can also contribute to altering motivation and changes in pain-related memories. So for those of you that know a little bit about the neurophysiology of having addiction or substance use issues, a lot of these will sound very familiar to you. We know that these brain changes, fortunately, can be reversed with pain treatment and psychosocial interventions, and including placebo. So it's good to just highlight the amygdala is the center of the kind of like the alarm center of the brain, and pain will set off an alarm in the amygdala that's very helpful for acute pain, because it's also the site where we have the fight or flight response. So we know that with that increases stress hormones and outflow of adrenaline, and all of those things actually increase pain. So when in the chronic pain setting, this alarm is constantly going off and is not beneficial to our long-term health. So this also points to the fact that we can use behavioural approaches to focus on calming the alarm system. So this is why having interventions such as CBT can be really helpful in reducing overall pain experience. Chronic substance use also changes, causes changes in the dopaminergic and noradrenergic pathways. When an individual stops using substances and is in the withdrawal phase, then we see an increase in noradrenaline and a decrease in dopamine, leading to all of those things listed there. I won't go through them all. But what happens is that we know that all of these experiences increase the experience of physical pain. We can't ever talk about pain without talking about the emotional component of pain. If we look at studies where people don't have an emotional connection to pain, then having a super painful condition doesn't even bother them at all. So what's really, it's very key to the experience of pain and key to the quality of life for people with pain is the emotion that they experience in conjunction with that pain. I want to shift gears a little bit here to talking about opioid-induced hyperalgesia, because we're really focusing today on folks that have opiate use disorder or are on opioid medications for agonist therapy. So opioids act at all levels of the nervous system, and they actually, when taken long-term, so that's anything for longer than 2 or 3 weeks, can induce changes that increase pain sensitivity. When we progressively, as we take opioids for an extended period of time, there is less of an analgesic effect. So in other words, we become tolerant to the analgesic effect of the pain. So works great to start with, and then like, oh, my pain's back, my pain's worse. The morphine worked well before. I think I just need a higher dose. So then we see how we run into this problem of working collaboratively with our patients, increasing the dosage for a short-term response, but not a long-term response in terms of that analgesic effect. We know about opioid-induced hyperalgesia from a number of studies and how it actually causes an increase in pain experience. I've got a picture there of a hand in an ice bucket. That's to remind me that that's a cold pressor test, which is often used to measure a person's pain threshold and tolerance to pain. So in one study that I often cite, where they had a cohort of patients who are on methadone maintenance therapy, not necessarily with a chronic pain condition, but were just on regular methadone treatment, and compared them to a group of people not on any opioid therapy, we could see that when asked to plunge their hand into a bucket of iced water, they were, it took about half the amount of time to say, oh, this is painful, and then much more quickly had to pull the hand out of the bucket of ice water compared to people that were not on methadone. So this is in the absence of any pain. We just know that the experience of pain is experienced more quickly, and the threshold for that is much lower. Then let's take a look at actually a little bit more about opioid withdrawal. I kind of mentioned already that we have a release of noradrenergic and other hormones, collectively known as catecholamines, during withdrawal. These can actually cause inflammation in brain tissues and also neuroimmune responses, all of which increase pain and discomfort. All of this is reversible if we reduce the dosage or exposure to opiates. I'd just like to highlight a paper that my very good friend and colleague, Dr. Lornette Reeb, who a lot of you will also know, she did some original research a couple of years ago and coined the term of WISP, which is withdrawal associated injury site pain. And this is an interesting read. She surveyed and interviewed a large number of her patients and established that there was a phenomenon of when they were trying to taper off their opiates, old injury sites that were previously not painful but had been painful years and years before suddenly became active and painful again during opioid withdrawal. The good news is that with persistence, with the withdrawal syndrome and the withdrawal state, that pain does eventually diminish, but it can be very intense and really contributes to returning to illicit opioid use or the inability to come off opioid medications. So how can we mitigate opioid-induced hyperalgesia and this withdrawal-induced hyperalgesia? Fortunately, we have lots of ways of managing this. So the first one is either lowering the opiates, which will generally have a good effect. However, that's tempered against the withdrawal induced pain. So sometimes we have to do that slowly. What may be more appropriate clinically is to try an opioid rotation, particularly either to methadone or buprenorphine. And I'll talk more about those treatments later on. If we're looking at non-opioids, our next category of medications that's very helpful for treating opioid-induced hyperalgesia is NMDA antagonists, such as ketamine and dextromethorphan, and COX-2 inhibitors, which are non-steroidal anti-inflammatories that have a specific effect on NMDA system as well. We have our gabapentinoids, which can be helpful, and then alpha blockers, such as clonidine and dexmedetomidine, which is an intravenous form of an alpha blocker used in the hospital setting. There's a number of other medications, and don't have time to go into details of all of these things, but all of these have shown good promise in managing opioid-induced hyperalgesia, and in particular, toll-like receptor 4 antagonists. Interestingly, naloxone and naltrexone act as antagonists on these little brain receptors, and we can use those in very low dose, so not necessarily for our patients that have opiate use disorder, but naltrexone in the kind of dosage range of 5 milligrams and below can be used as an analgesic, and then some neurosteroids. So interestingly, we have some very common goals in the management of pain and substance use disorders. And I think it's good to highlight this because we're kind of, when we're treating chronic pain, we need to treat the substance use disorder at the same time. And often the goals and the techniques that we have for doing that are the same for both conditions. So we really want to pay attention to managing any sleep disturbance and any mood disturbance. We know that if patients don't get enough sleep, then that can increase their pain sensitivity and ability to cope with pain during the daylight functioning hours. We need to co-manage pain, mental health, and addiction. We've seen the kind of this complex interplay between the three. We want to use non-pharmacological and pharmacological approaches as much as possible. And in particular, we want to eliminate any unnecessary medications and substances. Every medication has side effects, so we want to avoid that as much as possible. Overall, we're looking to reduce suffering and distress, improve quality of life, because that's what it's really all about, and restore functioning. So managing pain more specifically in opiate use disorder, we need to incorporate our non-opioid pain management strategies, and they're going to be very varied depending on what the pain generator is in the individual patient. Some different treatments work better in different conditions, and again we need that combination of the two, non-pharmacological as well as pharmacological. In our patients that require opiate agonist therapy because they have active opiate use disorder, then we want to be careful in choosing an opiate agonist therapy that is going to be good for both. Just a quick chart here looking at the non-pharmacological treatments. We're going to possibly talk a bit more about this at the end after the case, so I will leave that, but just to know that there's a significant amount of research supporting all of those interventions. So let's get to the medications. I've mentioned at the beginning that we recommend buprenorphine and methadone and slow-release oral morphine. You'll recognize this as the order of our treatment options for managing straight opiate use disorder. And I believe that we also would like to use them in that order for patients that have chronic pain in the setting of OUD as well. Why do I say that? Let's take a look at buprenorphine as our first-line treatment. So we know that it treats opiate use disorder very nicely and has an excellent safety profile. We also know that it is very good as an analgesic. And a lot of people are often confused about that, and particularly our patients might not understand that it is actually a good analgesic as well. One of the reasons for this is that not only does it act on the mu opiate receptor, but it acts on other opioid receptors, which independently can have analgesic effects. So in particular, the kappa receptor, the kappa opioid receptor, it has an antagonistic effect there. And that's a receptor that responds to dynorphin, which is one of the endogenous opiates that has side effects of dysphoria and depression, etc. When we're using buprenorphine, we can split dose to either 3 times a day or 4 times a day. A bit hard to find really good literature on this, but certainly a lot of anecdotal, and it is referenced a lot in the literature, that the analgesic effect of buprenorphine may well be a little more soon after you take it rather than 12 hours later. And then there's those other benefits of being on buprenorphine versus other full agonists. A very good study that we often reference is Deitch et al., who looked at a number of patients that they switched from a full agonist, such as slow-release morphine or methadone, over to buprenorphine. And this was in a pain clinic. It wasn't a substance-using clinic. And they found that the majority of patients had a significant improvement in their pain scores. Let's turn our attention now to methadone. Again, we all know it treats opiate use disorder and it treats pain. However, we don't usually initiate methadone as a first-line treatment for pain outside of the OUD setting. The reason for this is it requires more specialist management. There's not a lot of docs out there that do methadone specifically for pain. Anyway, but we're talking about it in the setting of opiate use disorder. Again, we know that we can split dose for enhanced analgesia. And then there's some of the, one of the risks of using methadone is there an increased risk of overdose compared with buprenorphine. One of the nice things about methadone is that there's less of that withdrawal-induced pain. If patients miss doses, then that's nice that they're not going to be plunged into withdrawal and get that increased pain as a result of that. Finally, we have slow-release oral morphine. Now, this is the one that probably is not going to be up there in your choice of managing chronic pain in the setting of opiate use disorder. Why? Because we've already heard that full opioid agonists, such as morphine, actually cause pain through the mechanism of opioid-induced hyperalgesia when we're on it chronically. And so we have very little research anyway on the setting of slow-release oral morphine and pain management at these higher doses. There is a lack of evidence for adding a second opioid to your opiate agonist therapy. We do see it a lot. We can recommend it when we're treating an acute pain. So if someone is on opiate agonist therapy and they have an acutely painful condition, then adding a higher dose short-acting opiate is indicated. But adding it on for long-term treatment often just increases that baseline opioid tolerance, and that in turn increases opioid-induced hyperalgesia. So we really want to look at maximizing and optimizing the non-pharmacological treatments. I've already mentioned that we can do split dosing and that we can consider lowering or rotating the opioid. And then importantly, there are a number of interventional procedures that should be considered in some conditions, and all of those things such as nerve root blocks, ketamine infusions, sympathetic blocks, etc. As well as, importantly, all of that psychosocial support. I'd just like to point out that Pain BC website is an excellent resource that houses many other resources and options for our patients, and great education for healthcare providers as well. Just a reminder that opioids should not be prescribed in conjunction with other sedating drugs because of the heightened risk of overdose. We want to coordinate care to ensure that other prescribers are aware that our patients are on opiate agonist therapy. We can't practice in silos here. We really need to work together with patient psychiatrists, family practitioner, as well as a substance use prescriber to maximize good outcomes for our patients. Patients may require OAT indefinitely, and its use should continue as long as a patient is benefiting from treatment. So as opposed to patients that don't have opioid use disorder, we're not going to be pushing people to minimize or come off their opiate agonist therapy. Finally, in summary, substance use, injury, and traumatic events can significantly alter pain sensitivity. Pain can also affect our patients' sleep quite significantly. Their substance use, not just opiates, but other substances such as alcohol and other things that they might use to help distract from the pain, and underlying mental health conditions. And we must manage all of these things at the same time. Prioritize the use of non-pharmacological and non-opioids, and choose a good opiate agonist therapy for managing our opiate use disorder. And finally, avoid co-prescribing a second opioid in the chronic setting. My final piece that I just want to add to this is it is very, very difficult to manage chronic pain in the setting of an active opioid addiction. So really we have to encourage our patients to accept treatment for their opiate use disorder, and then we can much more successfully treat chronic pain. Thanks, Megan.